your patients are on NAVA and you need to wean them and extubate them. Dr. Lawson, you talked about your one patient on NAVA for up to 10 days. Do you think he was on NAVA for 10 days because he needed to be? Or are you struggling, as we are in the neonatal world, of coming up with some really good criteria of when to take the endotracheal tube out? And especially with the ability to now move to non-invasive ventilation, should we be pulling these tubes out sooner?
With that one patient for
use the microphone.
one patient for 10 days, as I said, we did spontaneous breathing trials with him, and he eventually passed his spontaneous breathing trials, so it was left up to the primary team. We would then relay the information back to them saying he's ready to be extubated according to our criteria, and they went ahead and took him off NAVA and pulled the tube out. So we, as I said, we knew that introducing NAVA was going to be something challenging, to our institution. So we tried to really keep our protocol as similar to our existing protocol as possible. I know other people, you've read the papers describing other ways to wean NAVA, to gradually reduce it, to look at various settings. We didn't do that. We just kept it really simple. We found it worked in our situation. There may be better ways to wean NAVA. We don't know, but this sort of worked for us. But it really was, the goal was to just try and keep things very simple. And that's when patients came off NAVA. They passed an SBT, and they got extubated.
Antonio? And everybody, please introduce themselves.
Antonio Pesenti from Milan, Italy. I'm puzzled by the diagnostic capability of the EDI. In this way, what does the panel think about the diagnostic meaning of the absolute microvolt value of EDI?
That's a good question. I had that listed as well.
I think I have a mic. I'm on here. You hear it? Yeah. So I think the...
Is your microphone on?
Yeah. Do you hear me?
Yeah, okay.
Okay, good. So the absolute value of EDI is a little bit puzzling because we do have deviations. And that is mainly anatomical. I mean, with the way...
Sorry, just before you go, why do you think it's puzzling? That they're different? I'm surprised that it's actually so similar. I would have thought it'd be all over the place.
Well, I would say like this. There is today, I don't know, Jennifer knows better the numbers there, but there is like a large number of studies being published, and they all show the same kind of like 10 to 15 microvolts in every ventilated patients. Like that's where you put them on average. And there are patients who do have, say, higher activity than that. And it is certainly that for anatomical reasons, some people have a more tight sphincter, like the esophagus, and it's more...
You're talking about the esophagus? I just want to make sure. Yeah. I just want to make sure.
The crural sphincter kind of thing is closer to the electrode. But overall, I mean, this is what we spent or wasted or whatever, half our life. That was to get that, I would say, B signal out. Because it's like it really has been for all years how to take out that signal appropriately. And I mean, today, everyone says we should do this non-invasively, we should do it. And I say, fine. But then first do the same thing, come up with something and show that it works. So we have a signal today that we know works like in more or less every patient. If you don't see the signal, you have some kind of diagnostic value. So 0 definitely means something on this signal. But if you have 10 microvolts or 50 or 100, I would say for the average patient, when we did like comparison between groups of patients, if you take an N of 5 or 10 in each group, you will find significant differences if you do something in this signal. But within these 20 patients, there might be 1 or 2 oddballs that have a little bit higher activity, or they have a little bit lower activity. And our current work now is that we are looking at the spectral contents of the signal. We can correct for this. So you can see on the power spectrum, if you have a diaphragmatic hernia, like the signal is far away, your power spectrum shifts to the left, and thereby you can correct the amplitude for the loss in frequency. So we are getting there. But again, I mean, this is all in its infancy again. So I mean, there are so many things to do, like every day on this mode. But
Jennifer, you're not officially on the panel, but
Can I add something
okay.
though? I guess I understand what Antonio asked, which was a bit different. Okay, as a diagnostic tool, well, is excellent when you need to assess whether you have a phrenic dysfunction, a diaphragmatic paralysis. If you have the doubt, you put the catheter and you give an answer. When it comes to the value of the ADI, to me, you can use it within the same patient to observe variations. But I am sorry, I don't have a study or data, but in my experience, you cannot compare 10 microvolt in one patient with 10 microvolts in another patient. And which also means that the level of assistance is not an easy game to play, because if the level of ADI from which you start has not a meaning in itself, then also the gain has to be different. That's why I'm not so interested in finding the ideal NAVA level, which I believe is different patient from patient. But this is a personal gut feeling.
Stuart?
I think, follow on that, and actually I'd like to ask a question. So is there any correlation between EDI and PDIs, both within patients or comparing them? I mean, can you look at a certain level within comparing patients and say, okay, so they're pulling a bigger EDI, so it correlates with a bigger PDI and a greater diaphragmatic effort? One of the things that made me ask that question was this ineffective triggering. So I'd see these patients that come along and their EDI were good, they'd trigger a ventilator, and then they'd have a diaphragmatic contraction potential, they'd have an EDI, which was a good EDI, and they wouldn't trigger the ventilator. Why? What's happening there? Clearly, the diaphragm's got an action potential, but why is it not triggering the ventilator in that situation? So,
well, we just finished one study in China, that was a weaning trial. We just looked upon how much volume and as well pressure can you generate for a given diaphragm activity. And we found that, first of all, patients who failed weaning had higher diaphragm activity than patients who did not fail weaning. So back to your point again, Antonio, these numbers do make sense. So some patients who have very high drive are less likely to come off the ventilator than patients who have a low drive, if they are not sedated, if they are not on assist. So if they spontaneously breathe. But the other part is the coupling, as Stuart is talking about, is a whole different beast. So we find here that patients who cannot get off the ventilator have about, in China at least, 20 ml per kilogram is what they generate, whereas the guy who comes off the ventilator is 40 ml per kilogram.
Did you say ml?
ml, 40 ml per kilogram, yeah. So, sorry, 40 ml per EDI, sorry. Sorry.
That was huge.
Sorry. Per microvolt, sorry, yeah, 40 ml per microvolt. So, but the thing is, the big difference here is again, not true for every patient. So if you look upon the predictability of saying, you go home, take out the tube, you stay here, no, we can't do it for everyone yet. But Leo Honks is doing in Holland an N of, do you have the N for your apps poster now, 15 patients or something like that, and find exactly the same data in Europe. And they get a significant difference already with 15 patients. They measure PDI instead. So, yes, there is value.
Jennifer, I know you've been thinking about this. Do you want to address this particular? Because there's a question at the back otherwise, but I hope you address this.
I was going to confirm what Paolo said, which is within the subject. If you do an intervention, you can obviously compare the EDI. But I'd like to ask the neonatologists who use NAVA clinically in the room, because the literature and from what I've been seeing at the bedside in my visits around the world is that most of the babies are around 10 microvolts. And if you see a baby that has 80 microvolts, that sets off an alarm to you saying, that's too high. And I don't know if any of the people who use it clinically, because there's no pediatricians up there, so. There you go. Okay.
So we'll get the answer this afternoon.
I have a quick question for Paolo. So I was actually really surprised with a very heavily sedated fentanyl subject that you showed just the waveforms, that there was still 10 microvolts of signal left. I mean, there was a dramatic drop, but it's not like Stewart's graph that showed flat EDI with the sedation. So, number one, I was a bit surprised about that. Number two is how you didn't manipulate NAVA levels in that study. So how do the reflexes respond when you're that heavily sedated? You might have an EDI, but does it move or do anything if you change the ventilator settings or?
Yeah, well, I don't know. Comparing, no, you have it.
Oh, okay.
Comparing with his data, he used midazolam and fentanyl as primary type of sedation. You know, ICU patients frequently have other problems, which are mainly renal problems, hepatic problems. Even if you change the dose of fentanyl, you may pay other drugs that have been infused in the preceding days. In our study, the real difficult aspect was to have pure patients with no other sedative infused in the month before, which means they were fresh, so forgive me, I mean, I know they are not fishes, but fresh patients. That's why I said 14 is a huge number, and I'm not going to study one single, it took me 2 years to do this stuff. Because we needed to have patients with normal renal function, with everything. I mean, they were quite composite. So I guess no one has data that are as clean as ours, at least clean in the terms. Propofol is propofol, remifentanil is remifentanil. What happens when you change the settings for a given level of sedation? Well, the interaction between, you remember the loop I showed? I mean, mechanical support and sedative are probably going to interact in some way, but this is something we have next to study. What I can tell you is that no one in a reasonable world would use only propofol, and maybe sometimes, yes, we do it, but even only remifentanil is quite unusual. You usually combine the two drugs, and the interesting question is, what happens to drive and timing when you combine the two? But unfortunately, I ran out of time, and I couldn't show you the two slides.
You really want to show those slides, don't
No
you?
way.
You just,
They are too difficult.
I saw some hands up in the back.
Could we? I would like to comment on that.
Why don't you comment on it while the microphone's going back there?
Okay, so just for the point of looking at human data, looking at animal data, generally any species, it's really hard with sedatives to knock out breathing unless you hyperventilate. It is like, so we actually see breathing last after the heart stops if we try to overdose to death.
Yeah, which is what we saw, actually.
Yeah, it's really difficult to knock out. So the thing what Stuart shows here is definitely a combination of some sedatives, but definitely with over-assist. The ventilator does the job to get rid of the CO2, and you pop your CO2 below your sensitivity threshold, you stop breathing. That's just how we work. So I think it's a very important point to say that sedation does not make you stop breathing.
Question, yeah.
So the data that you present is very compelling.
Can you give us your name and where you're from?
Vivian Lee from Santa Fe, New Mexico. I work at a community hospital, and my question would be, my assumption would be in practical use, the population that you would use NAVA and benefit needs to be carefully selected for economic reasons. Are there any studies that have examined prospectively a certain population of patients who have been randomized to NAVA versus non-NAVA, and then endpoints such as tracheostomy or LTAC referral? Has that been done yet, or is that being planned for the future? Because ventilator asynchrony, you would, logically assume that, if you cure that, you would end up with less trachs and less LTACs and decreased length of stay. But has that actually been proven yet in a published study or a study that's ongoing? Because when you deal with hospital administrators, they want that data.
Good question. Who wants to address that?
I think, first of all, to answer your question, I think that the study that has shown that NAVA specifically would do anything in terms of like shortening your time of ventilation or so on, I mean, that study is still remains to be done. And I think what Paolo pointed out before today is that before you go into epidemiology with something that is new, we have to really know what we're talking about. Because if you take patients in one group who are on pressure support, who are perfectly synchronized, and another group of NAVA that are perfectly synchronized, and you let them wait for weaning, do you think you're going to see a difference? I don't think so. I think that the point here is that when we come into the problem of patients fighting the ventilator, being sedated, and then, as three studies have clearly shown, that you get patients staying at least a week longer when you can't manage the patient. Those studies have been done, and we've shown those in two times today. So there is definitely evidence to say that we can improve ventilation. Sorry, if we can't ventilate properly, and if we sedate more, we do run into trouble. But no study has shown the opposite. And the thing is, again, to design such a study, you would today have to go back, because these studies were like done with higher tidal volumes than we use today. So if you really tweak it and say that I'm going to have every patient on 6 ml per kilogram in pressure support, yes, you're going to get a pretty good synchrony. But you're going to also have a lot of patients who are not so happy with it. But if you say, as Paolo said, sometimes sedation goes too much on the other side too. Patients are actually not comfortable. Like, it's very hard to design these studies, because comparing two ventilator modes is not what you're doing. The thing, I think, is more you start off with a signal that you don't have today. I think we've seen the whole morning that this signal can learn us or teach us a lot of different things that we have no clue about. So they can be either not breathing or breathing twice the frequency or do whatever they want. The machine is still going to show 20. And I think that is the start point. If you come to that point and you start to use that knowledge in order to treat the patient, yes, I think you get into a protocol.
Paolo?
Yeah, I have to tell you that although my hospital is quite far from New Mexico, our administrators must be relatives in a sense, because I have exactly, they were probably original from Italy. Anyway, I have the same problem that you guys. As I mentioned it to someone today, to ask for 5 catheters, I can't ask more catheter at a time. I have to fill so many forms that I get a pain in my hand at the end. And you know, the comment of the economy people in the hospital is, yeah, but you have the same ventilator. Why we should add the burden of an extra cost represented by the catheter? We bought you the ventilator. What the hell you want? And he said, yeah, okay, but if I use this, is because I believe this can improve the outcome of my patient. And you know, they say, well, prove it. Do you have evidence? And you know what? I have I know, Krista, I agree with you. I don't like, well, I have to tell you, I don't like evidence-based medicine. So I prefer another approach based on knowledge and response to the problem to the single patient. But I'm in the loser side, so we have to face with this problem. There is no outcome study showing a clear benefit in terms of clinical outcome. And for this reason, thanking McKay, which is supporting the study, I ask, and they share the opinion, that we probably need a study indicating whether or not using NAVA in a general patient population, we are going to decrease the time spent on mechanical ventilation and the days spent in ICU. Because you know, one catheter costs me 180 euros or something like this. 1 day more in ICU costs 3,000 euros. And you know what? Sometimes means to transfer a patient to another hospital, which is additional cost and burden and problem for the patient. So, I mean, we have to prove something. we are not going to see any difference in mortality unless we study huge amount of patients. We are not going to see, I think we should try to see what might be reasonable, which is the time spent in ICU and in mechanical ventilation, which are more or less the same, at least in. I hope I answered your question.
I think this is an important question. We'll come back to it in the afternoon panel as well, because this is very important. Question up here.
Could
Also,
I have one comment on the cost
keep
side?
it short.
Yeah, very short. I think as the comment on the cost side is, I think when we talk about cost and so on, we take a lot of things for granted in an ICU or anywhere, and other things we don't take for granted. I mean, for example, if I go to the hospital, I pay at least $25 a day for park my car. That's like a cost I just accept. If I would say, like as we discussed before today, and this is one of my favorite things right now, that is, okay, if we take away all bed costs in the ICUs, in the hospitals in general, put the patients on the floor, save the money. These are very expensive devices. How many lives do they save? How much do they shorten your time in the ICU? I don't know. I mean, I think sometimes the discussion is we have to follow things from a scientific point of view. We have just learned that we can fix something that was broken. Now let's sit down again and start to talk about seriously where are we heading with this before we start to let money drive us into science, because there's going to be tons of studies coming out of NAVA comparing NAVA to everything, because it's public domain. You can take it, you can do whatever you want.
question. Please introduce yourself.
Right, sure. Alan Merritt from Loma Linda University. The question from New Mexico, though, is extremely relevant. We have here probably the world's experts in the use of NAVA. And I'm certainly a supporter, and we use it in our unit. But, you know, I've done neonatology now for 40 years, and I've seen a variety of cycles. There was another very famous Canadian, Dr. Charlie Bryan, who in the 1980s strongly advocated high-frequency ventilation. And it's still used, but clearly when those randomized controlled trials were done, and although one can fault the ventilator chosen, the fact is the results were actually worse. And we have all grown up in an era of evidence-based medicine, although senior clinicians with gray hair or no hair understand that clinical observation are very, very valid because they are related to your own patient population and your own combination of therapies that do a lot to affect individual outcomes. But when we were visited with Marquet a couple of years ago, my basic challenge was we have the creme de la creme of respiratory physiologists in terms of respiratory drive. Our challenge to you is to devise the trial with the appropriate endpoint that is in fact convincing in an evidence-based way that allow us to go to our administrators and not have to justify not only another machine but other catheters. So clearly some of the endpoints, shortened period of ventilation is a very important one. Or more successful extubations is another very important one. Whether we will change, for example, mortality is probably irrelevant. And whether or not we reduce BPD may be irrelevant. But if we can have tangible measurements using the methodologies that are demanded in an era of extremely evidence-based focus, both scientifically but economically, then and only then will a technology that you now say you've moved along from be really readily more accepted. And so that's really the challenge. It's understanding it, but also devising the trial that proves what you need to prove.
I think it's a very good point. Wait a sec, Krister. A very good point, and it actually we will address. We are going to address it now. There's it's interesting. The high frequency ventilation example you gave is a very constructive one, a very interesting one because I wasn't involved on the neonatal side, but I'm quite familiar with high frequency. And it's interesting because that trial was well done from an epidemiologic perspective, but it was done a little bit too early actually because it was done before people really understood how to use high-frequency ventilation. In fact, one of the possible reasons that it was, is, for example, they didn't use enough recruitment. So I think that you really have to understand the physiology, but that doesn't negate what you're saying at all. I agree that there's some things that, I mean, we should talk about. What are the most likely patients to benefit? What might the trial look like? I think it is important to address. Krista, right behind you, has had his hand up.
Yes, I think.
Give your name.
Yeah, Krista Strom from Piteo, which means beer in Chinese. You brought up the high frequency stuff, and I think tradition is so strong when you talk about economics, because actually the disposable set for the oscillator is the same cost as the EDI catheter. Nobody would question that. Yeah.
More, but I think that the point that's been brought up is a good one. You want clinically important outcomes, not just the physiology. You know, I think that's, if in this day and age, when you got the economies doing what they're doing, you have to show clinically important outcomes.
And I guess my final point would be that it may well be in separate populations that its performance will be very different. A good example is surfactant. Very, very effective in infant populations, but using another and perhaps less effective surfactant, Roger Sprague demonstrated it just doesn't work. And so, or the disease is not really the same. And perhaps, therefore, avoiding unnecessary expenditure. So we're really at the clinical level and at the administrative clinical level challenged to say, we need to provide the evidence unequivocally that what we're doing is superior to what we're doing now.
Can you that two rows back? And again, please give your name and.
William Stigall. I'm a pediatric cardiac intensivist at Medical City Children's in Dallas. I had a couple questions, and it sort of is tangential to the economic question. In that, I think one thing we have to keep clear though is the ability to show these changes is going to be very small. And so the changes we're talking about are going to be small, and so therefore the trials have to be large. And large trials, like your 14 patients that took you 2 years, take a long time and a lot of resources. And so, it may be that technology has moved beyond by the time you're actually able to, finish a trial. I asked that because one of the patients I've had that I've used it on, NAVA basically showed that we had diaphragmatic, not paralysis, but paresis and disuse. And I think a lot of that has to do with, in the pediatric world, we use a lot more command modes of ventilation than it sounds like you guys are using. So that if a patient in the pediatric world is on pressure support, that's a weaning mode towards extubation, and it's just not common to use pressure support for long periods of time in a pediatric cardiac ICU anyway, or a pediatric ICU. And so my question is regarding diaphragm disuse. Are there data that also show that asynchrony is worse in modes like pressure control, PRVC? I would presume they are. And microvascular, micro changes, that Jaber study in the Blue Journal showed that you had very quick changes in the microarchitecture. But what's not clear to me is how fast clinically that happens. And that gets back to my other point is, so this patient that had diaphragm weakening has shown clinical improvements using NAVA sprints. And so every day I put him on a NAVA sprint where he's on NAVA for a while. He gets very agitated with it, and you can tell it fatigues him. But over a period of weeks, he's gotten better. And so my question is, so the PRVC command modes causing diaphragm disuse, how quickly does that happen clinically, and how quickly do you think you can get recovery using methods like this, especially in pediatrics where we don't use pressure support all the time?
Okay, I'll try to answer the first question. 14 patients where you do a physiologic study like this, where you have 6 trials and you record data for 45 minutes, I don't remember. Then you have to stop 1 hour between two. It means that you start the study 6 a.m. and you finish it 12 p.m. And the fellows are not very happy with you when you put them all this burden. It's different to evaluate patient in a clinical randomized controlled trial where there are other types of difficulty, but the rate of enrollment is clearly different. Plus, we needed patients with specific characteristics. So don't take those 14 in 2 years as a standard. Second, we are, I believe, and I think from the auditorium, more or less everyone agrees that despite this is probably not perfectly reasonable, because it's true, no study has ever shown that no bed is worse than having a bed in the ICU, true. But today we have to face with this problem. And as far as I understand, we have it in Novara and Vercelli, we have it in Santa Fe, and we probably have in many, many places. Today we have to face the problem of costs. And the only language which is accepted even by people who are involved in economical problem, even though they do a master in medical economical problem, but is evidence-based, is a randomized controlled trial. This is the key word. And there is nothing we can do. Me too, I don't agree upon this approach, but this is what we have to face. Third, which is not related to your question, but I need to find a way to say it. People believes that NAVA, and this is a major limit of this technique, is for the top guns of respiratory physiology. People believe this is a very complicated. I tell you something, many years ago in a previous life, I worked in a weaning center where we received patients from the ICUs to wean them. And you know, there was a biphasic type of behavior of these patients. Patients coming from excellent ICU, I remember I was taking patients from Antonio, we didn't wean them. The patient remained on mechanical ventilation or died or whatsoever, or it took an infinite time to. From smaller centers, maybe not so skilled with mechanical ventilation, sometimes we just disconnect the patient and they were breathing on their own. At the same time, I think with NAVA, it is exactly the same. I personally expect the best results in those units who are not university teaching hospital without a lot of staff working on the patient. I mean, NAVA is a kind of a self-working system. I mean, it's more difficult to make mistakes, although we have shown it's more difficult to over-assist the patient. It's almost impossible, with a few exceptions that there are. No one talked of the risk of under-assistance, which is a neglected topic, but the risk has to be considered. No one has ever studied the risk of under-assistance.
I think your point is a good one about, if you think about patient-ventilator dysynchrony, which actually is a complicated issue.
Could we go back to the Chabert study?
Yeah, in 1 second. Patient-ventilator dysynchrony is an interesting issue. It's quite difficult. That's one place where NAVA makes it very simple.
Yeah.
So you don't need an experienced clinician at the bedside. That I think there's no question. And so in terms of the study, by the way, you know, I agree. You need, if you're looking at mortality, and you take all comers, it's almost an infinite study. I think what this group should be thinking about is where is it most likely to be effective? And for example, if you look at the outcomes of patients who have high patient ventilator asynchrony, greater than 10% index, their outcomes are much worse. If you focus on that patient group, and there you think the hypothesis is that NAVA will improve synchrony, and if you think synchrony is important, that now becomes an interesting study that probably wouldn't take thousands of patients at all to show an outcome difference. So that's the kind of thinking I think we should have in terms of the kind of study to do.
Back to that point of the Chabert study and also the Levine study, and there's tons of these studies out there, and we are actually working on one now. It's been very much about over-assist and disuse, and that is, of course, one factor. And I think it's like what Stuart is showing, patients who are difficult to wean are usually forgotten and placed on something that works. That means they are in storage. If they would be put on NAVA, they would not be in storage. We have shown this several times over, that's for sure. But the other part is in the critically ill patient, where we see these kind of drops very rapidly, 72 hours, 48 hours, and you lost 50% of your force. That is something different. That is not just disuse. And we are doing a study right now, that we finished, we're writing a paper in rats. What do we find if we do a pneumonia in rats after 48 hours of pneumonia? Because people use like LPS, they use all kinds of things, they put them on CPAP right away. I mean, they are not even in respiratory failure. They put ventilation on somebody who got a toxic thing, but they put them on before they actually get into respiratory failure. But give somebody a pneumonia for 48 hours and see how they look after that. 50% of the diaphragm function is gone. Bye-bye. Just the pneumonia itself kills like the force in a rat. And it takes 48 hours. We put them on NAVA for 6 hours. That recovers 50% of the force. Explain that. I don't know. As I'm saying,
any other questions or comments from the audience?
I think that's very interesting. Clearly there's more going on than just at the structural level then. So sort of a related question is, how much do you listen to what the patient's doing? What I mean by that is, so when I put a kid on NAVA, I'm very much looking at what the EDI signals are, and we had this discussion that the EDIs may not mean much patient to patient, but when you're putting a new patient on, all you have to compare is your old patients. And so then you have a baseline you can sort of trend on this patient. So when you put a patient on NAVA and their EDIs go through the roof, 50, 60, 70, what I'm doing is I'm titrating up the NAVA. Then if you titrate the NAVA up enough, you're going to get elevated peak inspiratory pressures. Obviously you can't do plateau pressures on these babies, but you assume that their PIPs are going to be corresponding to high plateaus. In the same way, NAVA has helped me looking at EDI mins of going up on higher PEEPs. So in the peds world, we're not near as cavalier as you guys are in the adult world of using high PEEPs, but I think it's probably because we don't use enough PEEP. And so I've placed patients on higher PEEPs than are found in my units based on looking at NAVA numbers. So at the end of it, though, you end up having a kid who was on these storage settings that looked okay, and now I have a kid who's on NAVA with elevated PIPs that are dinging the ventilator and alarming people, with an elevated PEEP that's alarming people. But clinically, I know the kid's more comfortable, and his gas exchange is better. So how much do you listen to patients? And are there numbers that are, I mean, should I care about a PIP of 38 on a kid, knowing that, 75% of the rest of them are lower?
Who wants to take that? That's same more large at the pediatric group. And I wonder whether we shouldn't, because we're going to have pediatric folks talk in the afternoon, maybe leave that question, partly because we're about 10, 15 minutes over. But I think this question in the pediatric group we should ask in the panel coming up. And the other issue that we haven't discussed as well is, how do you set the NAVA level, which you sort of hinted at. And there's a whole bunch of things we haven't really discussed. So I'll give you the last comment.
Can you just add one sort of broad overview subject? And this is the job of trying to sell other people in my hospital to actually buy into the idea of using NAVA. I mean, the quoted figures that we spend in adult ICUs, we spend 40% of the time weaning patients. In our institution, as you said, we've got pretty good at doing the spontaneous breathing trials. We've got pretty good at turning off sedation. We're very good at getting patients out of bed and doing physical therapy with them. We seem to be doing everything kind of right. We've tweaked everything that I think has to be tweaked, and we're still having patients sitting on the ventilator. It is, trying to wean them. I think it's almost time that, where do we go from here? We've done the tweaking. It's almost a case of if we're going to move forward and reduce the amount of time that patients spend on ventilators and ICUs, we've got to come up with a different idea. I think, we've done what we can do with what we've got at the moment.
Great. On that, we can, final comment? We can't hear you. Hold on.
We have NAVA. We have catheters. We treat them like gold. We're very selective in who we try to try to figure out who these people, who would be most benefited by using NAVA ventilation. One thing that we're toying with would be if they're not off the ventilator in 3 days, then making a protocol where they automatically go to NAVA, and then we, prospectively study, how they do with NAVA, like form two different populations. One would be the population where we would do what we normally do. One where we would, automatically put them on NAVA at day 3 and see if we have any different outcomes in trach and length of stay on the ventilator. But as clinicians, that's probably with NAVA, my biggest challenge is trying to figure out who do I put these catheters in who will really benefit.
Yeah, so the question, and that's one I think we'll address this afternoon, who does the group feel is the most likely to benefit from NAVA, which I think is an important question.